In this lecture, we will discuss junctional escape rhythm, including its mechanism, potential causes, EKG features, and basic junctional rhythm terminology. A junctional escape rhythm, which is also referred to simply as a junctional rhythm, occurs when the normal pacemakers fail to fire, in this case the sinus node and atrial pacemakers, and then the next available pacemaker in the conduction system fires in its place. In other words, the AV node senses that the sinus node did not fire, and therefore when its turn comes up and it reaches its threshold potential, the pacemaker fires. Okay, so if you look here, again we're showing our sinus node, which is this point here, where our conduction system starts. So we have this X here as it's not working, okay, no other atrial pacemakers are firing, and then eventually it comes to our junctional pacemaker here at the AV node that then ends up taking over and firing in its place. Now, some potential causes of junctional escape rhythm include severe sinus bradycardia. Okay, so imagine we have severe sinus bradycardia, so it's really low that eventually it gets so low that the AV node ends up firing. We could have sinus arrest, sinoatrial exit block, high degree, second degree AV block, third degree or complete AV block. Hyperkalemia can cause this, and so can medications, such as in the setting of beta blocker, calcium channel blocker, or digoxin toxicity. All right, so let's go through why this junctional escape rhythm occurs in a little more detail. If you recall, we have pacemaker cells located throughout the normal electrical conduction system of the heart, each of these cells with the ability to independently sustain a heart rhythm. The rate of spontaneous depolarization of these pacemaker cells decreases as you go down the conduction system. For instance, the intrinsic rate of the sinus node is between 60 and 100 beats per minute. The atria is slightly less than 60 beats per minute. The AV node between 40 and 60 beats per minute. And then the ventricle between 20 and 40 beats per minute. The rates may be slightly different in children as they are age dependent early on, although the general idea here is still the same with them. Okay, so if we look at our conduction system, remember, if we think of our sinus node, generally it's between 100 or 60 and 100 beats per minute. Okay, and our atria tends to be a little less than 60 beats per minute. Our AV node or AV junction tends to be between 40 and 60 beats per minute, its intrinsic rate, and then in the ventricles between 20 and 40 beats per minute. Okay, now you can think of these as safety nets in which there are different levels that serve as backups if the levels above them fail. Okay, normally these secondary pacemakers are suppressed by the more rapid impulses originating from above. For instance, the AV node is suppressed by the faster intrinsic rate of the sinus node. However, for some reason, the sinus node or other supraventricular impulses arrive at the AV node after the intrinsic rate of that ectopic pacemaker, then the AV junction will fire and may even take over the pacemaking function of the heart. And that's what we see occurring here with this junctional escape rhythm. Okay, so that's what's happening. We have our pacemakers up here in our atria and our sinus node not firing, and eventually, okay, this serves as our safety net and ends up firing in place of our sinus node. Now, just so you're aware, the main difference between junctional escape beat and a junctional escape rhythm is that the junctional escape rhythm actually continues at a regular interval with the AV junction taking over the pacemaking function of the heart. On the other hand, the junctional escape beat is simply one beat originating from that AV junction, but the rhythm is not maintained from the AV junction thereafter. Okay, you can have that grouping where you have bigeminy and trigeminy with these junctional escape beats, but again, the rhythm does not continue as we'll see here with junctional escape rhythm. Okay, now let's take a look at the EKG features. In general, we define a junctional escape rhythm as a regular rhythm with a rate between 40 and 60 beats per minute. They have a normal and narrow QRS complex and one with no relation to the QRS complexes in any preceding atrial activity. So that's the basic overview. Now let's look at this in a little more detail so we understand why we see what we see on the EKG. So we said junctional escape rhythm arises from the AV node, and therefore activation below that region, that is activation of the ventricles, will typically be normal. In other words, there is normal antegrade conduction of the impulse down the normal electrical conduction system of the ventricles, and thus normal intraventricular conduction. As a result, the QRS complexes will be identical to the underlying rhythm's QRS complexes. Okay, so typically regular and narrow if we have a rhythm that was present before. Okay, so what we're saying here, let's just clear this up. So the rhythm is originating here at our AV node. Okay, and what's going on is that as the conduction starts here, everything going down towards the ventricles to the right and left side will be normal, okay? And that's why our QRS complexes that we'll see will be regular and narrow in nature, okay? So notice that they're narrow. Everything below here is normal and narrow. Okay, so normal intraventricular conduction. Now there's also retrograde conduction to depolarize the atria. And because both ventricular and atrial depolarization are happening nearly simultaneously, the QRS complex and P wave will appear together. And depending whether the impulse origin was high, mid-level, or low within the AV node, we can see the P wave at different areas relative to the QRS complex. For example, at times the P wave may be buried within the QRS complex. At other times, you may see an antegrade or retrograde P wave. Remember, an antegrade P wave is simply one that appears before the QRS complex, whereas a retrograde P wave is one that appears after the QRS complex. Okay, so again, same thing we've been saying with these junctional beats and rhythms. All right, so everything's coming from here, and if it's both occurring at the same time, we may not see any of our P waves, okay? And we see that up here, okay? There's no P waves that we make out because it's buried within our QRS complex, okay? They're both happening at the same time. Now, if we say that atrial depolarization, so maybe it starts a little higher and the atria depolarize before the ventricles, in that case we may see an antegrade P wave, okay? Where the P wave comes before our QRS complex, all right? Now, if you can also see it if it was low, all right? Meaning that the ventricles may depolarize first and then the atria slightly after. In such cases, you may see the P wave actually occurring right after our QRS complex. Now, as we previously mentioned, both atrial and ventricular depolarization occur nearly simultaneously. And because AV nodal conduction makes up the majority of the PR interval, we will end up having a very short PR interval, or at least less than normal. And sometimes it may be even absent due to the fact that the impulse is originating from within the AV junction. Okay, so again, the impulse is coming right where our AV node is, or in that area. Okay, so because of that, we won't have that normal physiologic delay that occurs in that region, and because we don't have that and it's occurring right there, okay, we can have an absent PR interval, right, if the P wave actually occurs within our QRS complex, or it could be a very short PR interval. If this one occurs just slightly before, we'll have a very short PR interval, or it could be a retrograde PR interval, one that if the P wave's occurring after the QRS complex. Okay, so just realize that because everything's coming right here, okay, and the PR interval represents most of AV nodal conduction, we'll have a very short one, an absent one, or one that's retrograde. All right, so because atrial depolarization occurs in a retrograde fashion, we will see an abnormal P wave axis. Instead of the mean electrical P wave axis heading leftward and inferiorly, giving us an upright P waves in those inferior leads, like in sinus rhythm, we will instead have the P wave axis going in the opposite direction in the frontal plane, leading to inverted P waves in the inferior leads, 2, 3, and AVF, and upright P waves in lead AVR. That is, if we are able to even make out the P waves, right? They could be buried within the QRS complex. So what we're saying now is we're talking about that retrograde atrial conduction, all right? And what we're saying here is if we're able to see P waves, in other words, they're not actually buried within our QRS complexes, so we have this retrograde activation of our atria, okay? Now, normally the P wave axis is between 0 and positive 75 degrees, so in this region, okay? And if we put our leads here, here's lead 1, here's lead 2, we have lead 3 over here in lead AVF, okay? These are our inferior leads, all right? And then we have AVR here. Now notice that that red arrow is heading away from AVR, and that's why we typically see a negative or inverted P wave in AVR in sinus rhythm. And then we will see upright P waves in those inferior leads and in lead 1, all right? Now with this retrograde conduction, because the origin is coming from our AV node, okay, or this region here, it's heading retrogradely, okay? Now we have conduction going pretty much in the opposite direction, you can think of it. So because it's going away from these inferior leads, we'll instead see negative or inverted P waves, if we do see them in those leads, and we'll see positive or upright P waves in AVR, okay? So if you were to see this, if you imagine this is lead 2, okay, and we're seeing some P waves, they may be inverted in them, all right, in this case. Whereas if it was maybe AVR, we would instead see upright P waves, okay? In that case, maybe the QRS complex would look different. All right, anyway, so the main thing here that I also want to discuss is that this is a regular rhythm, okay? And it occurs at the intrinsic rate of the AV junction, which is between 40 and 60 beats per minute, okay? So this is important. Let's just look at this. So again, a regular rhythm, meaning that our intervals are occurring at equally spaced time intervals. So from one R wave to the next, okay, all of these R to R intervals are occurring at equal distances, okay, at the same time in between. So we have a regular rhythm, which is the one thing here, all right, and the rate that we're going to look at here is between 40 and 60 beats per minute, okay? So if we look at the rate here, we count 1, 2, 3, 4, 5, 6. So 6 of the thick lines between the R, each R to R interval, okay? So it's 300 over 6, and we get a rate of about 50 beats per minute, okay? Within that 40 to 60 beats per minute range, okay? So that's important to know. Now let's just end by going over basic junctional rhythm terminology. And this terminology is based on the rate of the rhythm. We will go from slower to faster rates. First, we have junctional bradycardia, which is defined as a junctional rhythm with a rate of less than 40 beats per minute. In other words, a slower junctional rhythm, so slower than we're looking at here. Next, we have this junctional escape rhythm, where we have the rate between 40 and 60 beats per minute, okay? The normal intrinsic rate of the AV node. Then we have an accelerated junctional rhythm, okay? So this is slightly faster, above the intrinsic rate of the AV node, but below 100 beats per minute. That is, the rate of this accelerated junctional rhythm will be between 60 and 100 beats per minute. And then lastly, we have a junctional tachycardia. And just like other tachycardias, the rate will be above 100, okay? So junctional tachycardia has a rate that exceeds 100 beats per minute. And one final point, you may hear a classification for junctional rhythms based on their etiology. This means that they may be either due to an enhanced automaticity in the AV nodal cells. This is known as an automatic junctional rhythm. And then there are those that are junctional rhythms that are due to a reentrant loop within the AV node, which we call reentrant junctional rhythms. An example of this would be AV nodal reentrant tachycardia. This is something we'll discuss in future lectures. All right, so hopefully this is all starting to make sense. Let's briefly run through our chart before we end here. So again, junctional escape rhythms occur when the sinus node or those atrial pacemakers are failing to fire, okay? And because of that, it's originating in that AV junction, and we're going to also have the anterograde conduction to the ventricles and retrograde conduction to the atria. Remember, some causes we went through here, okay, you can go through them on your own. Remember, here's our junctional terminology that we just looked at. Remember, based on heart rate. Bradycardia, okay, just meaning a slower rhythm, less than 40. Our rhythm that we were looking at here was this junctional escape rhythm between 40 and 60 beats per minute, okay? And then we have the accelerated junctional rhythm that we'll look at next, between 60 and 100 beats per minute, and then junctional tachycardia above 100 beats per minute. Remember, this is a regular rhythm occurring between a rate of 40 to 60 beats per minute. The P waves, remember, we can either see no P waves if they're inside the QRS complex, so just buried within. We can see antegrade or retrograde P waves, depending if the atria or the ventricles get depolarized earlier than the other. Remember, the axis of the P wave will be abnormal because it's now going, we're having retrograde atrial conduction, okay, so it's going in the opposite direction we saw here. There will either be the P wave to QRS ratio. There might be none, right? If the P waves are actually buried, we can't find them. Or there could be 1-to-1 if there's an antegrade or retrograde P wave present, okay? In terms of the PR interval, again, if the P wave's inside the QRS complex, you won't have a PR interval, okay? Remember, the PR interval consists of our P wave here and our QRS complex. So right up from the beginning of our P wave up to here. So if we don't have our P wave present, we can't actually have our PR interval, okay? If it is present, if it's an antegrade P wave, it could be a short one, or it could be retrograde if the P wave's coming after our QRS complex. Now, just so you remember, because if you see a PR interval, remember that the conduction is not going from the atria and then continuing down towards the ventricles. Instead, it's starting here at the AV node and conducting backwards, okay? So again, it does not represent atrial stimulation of the ventricles. The QRS complexes will be normal, right? 70 to 110 milliseconds in width, all right? There'll be no grouping and no beats will be dropped. Well, that's the end of this lecture. We discussed junctional escape rhythm, including its mechanism, potential causes, EKG features, and basic junctional rhythm terminology. I hope you learned something.